Bonjour, bonjour. Hello, everyone, and welcome to this week's webinar. It is a delight and a pleasure to have you with us. And I bring forward very exciting subject matter and very exciting panelists. So before we jump into what we're talking about this evening, being endometriosis and PCOS, and what are we going to do about those sorts of things, I first want to do two call outs. First of all, please, everyone, through the chat, through my panel, please wish our most beloved Dr. Lara Varden a very happy birthday. It is quite literally today, and so she is offering some of her birthday time to us this evening. So, bon fête, Madal, bon fête. So,
Well, thank you very much. I really appreciate it. And I will tell you, I love being here. I love doing this. This brings me joy and happiness outside of my family and spending time with my little granddaughter. There isn't any other place I'd want to be right now. So thank you.
well, thank you so very much. And I also want to take this opportunity to introduce a new panelist with us this evening. And you'd almost think this was planned, but I'm very grateful that she's joining us for this conversation because I think her perspective and her approach, both to healthcare and then separately to hormones, it really diversifies how we're looking at this and really well rounds us out. So without many more words, I'd like to introduce Dr. Tracy Steady-Hardcastle to us and give her a little moment to introduce herself and how she fits into the DNA company and the sort of medicine that she practices. Tracy, welcome.
Thank you so much, and happy birthday, Dr. Varden.
Thank you.
So one of the things that I say a lot at the DNA company is that I feel like Chinese medicine was doing a similar thing. So it was taking people's constitutional chi, their energy, and their environment, their lifestyle, everything that goes into it, their illnesses, all of that stuff, and how those two things interacted. And that's sort of epigenetics, right? It's like what you come in with and what you put on top of it. And so but my way is just a little bit uses different words in looking at it and has sometimes different approaches to dealing with things, but it's really similar. And so I think it all fits really well together.
Yeah. Yeah, I would offer in particular a lot of my training with both Dr. Mansour and then a doctor who used to work here with Dr. Winnie Su, who is very well steeped within traditional Chinese medicine. They used to often comment that genetics is simply saying what TCM does, but in different words, right? And so once you learn the similarities of the words, you can understand the flow between the two. They were just capturing genetic pictures before we had genes to express it as such. Yeah. So why don't we start diving into tonight's topic? And it comes at a beautiful time because I think historically, but more of recency, there's a lot of concerns around women's health and how we go about addressing it. So from a history perspective, we're going to be talking about two conditions, which if you have never heard anything about them before, they couldn't be more on opposite sides of the spectrum as to how they present and what causes them. And yet, quite literally, if you go into a majority of GPs' offices, the prescription for these very opposite conditions is exactly the same. And Dr. Maria, I think your mic's off, but I heard her kind of emphatically being like, exactly. um, so we want to start discussing both to the end of what exactly are these conditions, but also to the end of ensuring intelligent, careful, informed conversation and access that women have to healthcare is maintained. And that's something that we will be doing within these webinars, within the DNA company mandate and the care that we're offering people. So on that note, ladies, why don't we start jumping in by discussing what exactly are these two conditions? And I'm arbitrarily, based on the alphabet, going to pick endometriosis. Would someone, for the audience sake, like to just discuss what exactly that is, especially from that patient experience? What's happening if someone comes in with, hey, maybe I might have endometriosis. What are they feeling? What are they seeing? Maybe Dr. Murray, do you want to, if you figured out mute, there we go.
There we go. So endometriosis. So inside your uterine tissue, right? Your endometrial tissue is the tissue inside, and it's the tissue that brings blood supply and prepares the uterine lining for implantation for the egg. And so when you have endometriosis, what you have is a increased vascularity, so more blood vessels, more support going to it. And you also have endometrial tissue that has gone outside of its normal bounds. So endometrial tissue can also be attached to under other tissues. So the bowels, the ovaries, the fallopian tubes, and it's microscopic. So it's not something you can visualize just on a sonogram. But what makes it problematic is when your hormones shift over the course of your month and your estrogen levels climb, that endometrial tissue's job is to bring blood supply. So it's also going to cause pain and bloating and lots of other symptoms on top of that. And it leads to infertility and other issues as well. And I'm sure other people can jump in, but that's kind of my simplified form of what endometriosis is. And then there's also adenomyosis, which is a cousin to it, more painful, more problematic, more infertility issues.
Yeah, yeah. I'm glad you brought that up because I think that's the proverbial redheaded stepchild that no one thinks to discuss, but is very, very important to the family. Yeah.
Yes, very much so.
Yeah, no. Does anyone else have anything they'd like to add to kind of that commentary? I think I guess more the human side of it. I know several people with either undiagnosed or diagnosed endometriosis, and we'll speak to the complication of getting to the point of diagnosis, but many who have a working diagnosis of endometriosis, and their experience of life is much more a trying one. They plan their life around when they expect their period, their menstruation, because quite plainly, they will expect to be in bed for several days. Not only from the physical kind of, there's a lot of blood coming out and it's difficult to navigate the world because of that, but separate to that, simply the pain picture. So oftentimes people coming to see us, that's the first comment. My life revolves around my period. It is profoundly painful.
Yeah, and it can be very debilitating.
Sorry?
Oh, it could be very, very debilitating.
Yeah, absolutely.
If I can, mention,
Please.
getting into the genetic part of it, when you are talking about the pain, sensitivity, fatigue of endometriosis, in our reports, there are actually some genes that can impact or give insight onto that. For example, like the MAO gene. Okay. If you've got slow activity leading to altered neurotransmitter breakdown and, with the COMT, that could impact pain perception and emotional resilience that can influence that pain sensitivity, fatigue, which are often common in endometriosis. I mean, so these are aspects that you can look into your reports and kind of see. I mean, it certainly isn't going to change the fact of knowing that going, yeah, I'm in a lot of pain each month, but it can say, hey, in your genetics, this is an area that you're a little bit weaker. What can we do to help support these particular pathways to help alleviate some of those symptoms? And then there's also the fact of the inflammatory response and detox pathways. I mean, when you consider that, say, the presence of the GSTP1 gene. So we're talking about the glutathione conjugation pathway. Okay. If you're suboptimal in that, maybe over aggressive in the GSTM1, and you have no copies of your GSTT1, that could affect the body's ability to clear these inflammatory environmental toxins, because these pathways are very essential in managing inflammation, very critical for endometriosis symptoms, and that condition that is inflammation driven.
Mm-hmm.
So
yeah. I love that you're so beautifully touching on the idea of when you approach treatment for this. Typically it's, let's address hormones, but there's so many other avenues that as a practitioner, when you work with someone, that are considered, right? It's not just a hormonal picture. Yeah. And I think TCM in particular is so wonderful in summarizing that, right? Because you guys look not only at the hormonal side of things, but the impact outside of that.
Yes, it's holistic. And considering how long, I don't want to jump the gun, but how long it can take to get a diagnosis of endometriosis. I
Yeah.
think the average is like 7 to 12 years or something like that.
Mhm.
It's just complicated and difficult. And
Yeah.
frustration of patients who would come in and be like, I keep going to the doctor and they keep saying it's normal to have a painful period. You just have a more painful period than other people and things like that, and just not feel heard in that was very challenging emotionally. And so going back to Dr. Varden's point, if you have some of these other things going on in terms of your genetics, it can make that experience even worse of not feeling heard. And the autoimmune component to this and just the overall inflammation, I think it's not just it doesn't feel like just a gynecological problem. It feels systemic, both in terms of life, like the amount of room that it takes up in someone's life, to speak to Dr. Kostroman's point, and also that it in terms of the body. So
Yeah. Yeah. So why don't we give a little bit of voice then to the typical pathway of, if you have endometriosis, right? What is the typical pathway that people are taking from that first presentation of painful period to the point where you actually go to a doctor and you say, hey, I think something's up, right? And there's the ideal path, right, where you're quickly ushered off for a biopsy and you're diagnosed, and then we know what to do. But let's be also honest about the typical path, because I don't ever want to set women up for the failure of expecting that they'll get the ideal path. Why don't we talk about the typical pathway to diagnosis here and how that's done? Yeah, maybe Dr.
You're
Murray?
saying, I think so many women, they end up going, or women and young girls, let's face it, this starts as soon as you start menstruating, that, most of the time you present with pain, you go to the gynecologist. If you have a regular pap smear or even a sonogram, I think that's the biggest thing, is the regular office procedures that someone could do to take a visual of some of those organs cannot see it. And so it really requires a procedure, a biopsy, which is pretty invasive. So I think this is just me extrapolating, but I think a lot of young girls and women struggle and go through a lot of pain and suffering because of that, right? So often women often don't even get diagnosed until it might affect their fertility. So there is this sort of battle. I think it's also understanding we don't have good blood markers. We don't have ways to check it in a very passive sort of way.
Yeah. 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 I also hear commonly too that it's, to a degree, the doctor almost saying, hey, I don't know if we need to biopsy you. And their logic is, if we confirm this is endometriosis, I'm not sure it's going to change how I treat you. Like, having a formal diagnosis versus not, we already know you have these symptoms. Here's your oral contraceptive pill. Come back in 6 months and let me know you're doing better. There's an element of doctors, to a certain extent, they're like, I don't know what to do even if this is confirmed. So I don't know if I want to put you through that effort, or I don't know if I want to requisition for that effort. We won't assume their mind. But there's an element of just difficulty getting to diagnosis, because so what once you do have it, right?
Yeah. I mean, I think that just sums up a lot of what we just see in medicine, and particularly women's medicine, is, the cookbook, the flow chart that was created based on, really kind of overlooking women, goes A plus B equals C. If we don't have anything to do with C, they just go, oh, forget B. We don't even need to look at it. We're just going to skip over that because we don't know what to do with it. So you're right, because the only thing you really can do from a surgical standpoint in the conventional medicine mind is to scrape it off and remove it, right? Or have a hysterectomy. But, that's the next sort of leap, I would say. I wouldn't say that's the right answer, but that's where the conventional leap goes. Would you kind of agree?
By and large, yeah, it's at least the cases that I've seen, there's been incredible intervention of, here's the pill plus a lot of pain management. And unless you want a hysterectomy, you kind of have to suck it up and deal with it. And Dr. Varden's already alluded to this. There's much more than just sucking it up. We don't want you to make you feel like this is a suck it up conversation. We just want to be very honest about the lay of the land. And so I wonder if we pivot a little bit and define what PCOS is, and spoiler alert audience, the prescription of a pain pill, or sorry, the oral contraceptive pill is exactly the same here, even though this condition is going to be starkly different. Who would like to offer up to our audience the definition of PCOS? And for our audience's awareness, we'll then after that jump into the survey that you filled out so we know why you're here and how we can speak to you. And we'll transition with that information into what on earth can you do about it? What does your genes tell you about it? So who would like to offer up a definition? Who first wants to unleash the vegetable or the alphabet soup that is PCOS? What does that stand for?
Dr. Steady, you want to take this one?
Sure.
Okay.
It stands for polycystic ovarian syndrome. And syndromes are so TCM because everything's a syndrome. A headache, there are 12 different kinds of headaches. And so there's some fairly specific criteria, although now there are 4 phenotypes, which is definitely also more like in the TCM thing. But typically people have irregular or anovulatory cycles, meaning you don't ovulate and your cycles can be irregular. On an ultrasound, you can see multiple cysts on the ovaries, and that's where the term polycystic comes from. And also hyperandrogenism, meaning you have more androgynous hormones, more testosterone in your system. And so you can have symptoms of that, like maybe hair in places that you don't want it to be and things like that. But there's also this metabolic component that isn't even addressed in the name. And there is a movement to actually change the name of this because it's more than just having multiple cysts in your ovaries. It's like a whole big, once again, it's a systemic thing. And multiple factors that need to be addressed at once. So I'll let someone else pick it up from there.
No, I love that. I love that you have a happy relationship with syndrome because I think your medicine was styled intelligently around that. Whereas typically by and large within Western medicine, if you hear anything as syndrome, it means you have a bunch of symptoms. We don't know what to do with it. So we're going to toss it in this bucket and hope that we can figure it out later. And so syndrome, I think to Dr. Steady's point, she just said there's 4 different subclassifications of PCOS, meaning what we once all lumped together, we're now learning can be broken down differently. And so we're getting more discerning within the bucket of PCOS, within our alphabet soup, where you might fit, right? And so this to an extent will lend to, and I wonder maybe if Dr. Varden or Dr. Murray wants to speak to this, many different presentations of people who show up with PCOS. I think the typical thought was it was going to be an overweight woman with a lot of acne, and that's not always the case. Sometimes absolutely, but it's not always the case. Like what does the person look like who shows up with concerns of PCOS or that ultimate diagnosis?
Yeah, I think first off, the assumption that it was always this dominant sort of, it happens when somebody's overweight, and it's actually one of the things is you've got one of the phenotypes of PCOS is definitely excess body weight, but it's usually a smaller upper body and more what I like to call junk in the trunk for those of us that have a little extra, right? We have a little booty on us, right? So sometimes because we can't, huh?
Oh, I just said, yeah, the booty. Go ahead.
Right. That's right. Well, and it's because it's with how the hormones impact where fat storage is stored. And so one of those phenotypes is very much driven by insulin receptor activity and the lack of sensitivity. And it affects ovarian function and sort of increases the androgen side and affects estrogen. And so therefore, when girls go into cycling, when they start menstruation is where we often see it. And so that was always the classic mindset. But there's other phenotypes that don't really fit that classic situation. And we have what we call the very stereotypical and a kind of very thin PCOS as well, that doesn't fit that insulin resistance sort of pathway activity. And, personally, I look at that and say, well, that means we have a ton to look at, right? Because we don't obviously understand it as much, for sure.
And I wanted to throw out the fact, and I'm going to be transparent here for revealing information about myself, but also when you're looking at your reports and say your hormone profile is one of estrogen dominance, that doesn't mean that you could not be diagnosed with PCOS, which is more related, like what Dr. Betty was saying, more of that androgen dominant, because I am estrogen dominant in my hormone profile. But yet when I was younger, having children and everything else, I was actually diagnosed with PCOS. And, I was in good shape. I didn't actually, gain weight and have the issues that I had physically until after the car accident, which was after I was 30 years old. But I mean, I had been diagnosed and stuff like that in my mid to late 20s. I mean, I was like a size 4, 6, professional figure skater, running, very active and everything else. And it's like exactly the thought of, oh, well, large breasts, just not your typical, but yet, yes, I was diagnosed with that, as well as with hirsutism, which is that awful, hair in places you don't want them, namely like, chin, neck, the jawline area. And then oftentimes it will have like a darkened skin area around the neck. That's another sign for hirsutism. Also with some thinning of the hair. Well, granted, thinning, but I think that's more from stress and all the surgeries and everything else I had. But even still, your hormones are so nuanced and they are so delicate in such a way that it's almost like a teeter-totter, that it's on a very narrow spot. Like anything, almost could turn it either way, no matter what genetic profile you happen to have. But it is still good to know what your profile is. Do you convert progesterone to testosterone faster? Like I do. That's why I have a dominant profile, and that's through your CYP17A1 gene. But getting into what Dr. Tracy was talking about with the metabolic aspect, to be aware of your markers for insulin and insulin resistance, the TCF7L2 gene. This can be very important. Also looking at the other genes that are relative to that, your AME1, some of your other fat metabolism, the FTO gene, and how this works and how it can affect insulin. Because I also was diagnosed pre-diabetic, was put on metformin, and all these other things. Now, granted, I have shifted out of that and no longer have that diagnosis. I'm not on any of the medications, but it's still a reality that you can deal with these things, but you can also, through knowledge, through the basis of knowing what you have to work with your genetics, and working with someone who knows who can help move you out of that state, or at least alleviate those symptoms. So,
yeah.
And I think there's also acknowledging that it's also either a lack of progesterone or a lack of progesterone receptor activity and sensitivity, that is also part of it. So somebody could be estrogen dominant, obviously on their genetic profile, still have high androgens and relatively high estrogen and relative low progesterone, and that is one of those other sort of phenotypical experiences as well.
Yeah. I love that what we're touching on right now is really the importance of lab work, your genes, whatever that might be, but coupled with the insight of a clinician and that third party that is able to, with care, stitch it all together, right? Truly, because that's, I mean, there's complexity to endometriosis. There's a lot of complexity to PCOS, given it's a syndrome. Right. And the power there is sitting with a doctor and truly understanding what exactly is driving yours, so that you can tailor the solution outside of just here's a pill to that end. Yeah. Oh, I love that. Dr. Varden, Dr. Murray, Dr. Steady, thank you so much for kind of very beautifully articulating that. I wonder if the powers, oh, yes, ma'am.
Can I say one more thing?
Yes, please.
They just redid some of the guidelines for treatment for PCOS in 2023.
Ooh.
And a lot of it, wonderfully, had to do with lifestyle and bringing in more of a multidisciplinary sort of team to manage it
Mm,
in different ways. And I also guess I just wanted to put in kind of a plug for
yes.
herbs. Some
Yes.
of them can bring down LH and FSH. Some of them can prevent testosterone from converting to DHT. Like there are just a lot of these things, you know, to put it in, I would say it in a different way ordinarily, but I also am fluent in this because I have to be.
Yeah.
So there can be more subtle treatments than a birth control pill. There are plenty of nutraceuticals and plenty of herbs that can also be used to help manage this in addition to lifestyle things. So there are other options out there.
Yeah, and again, I think I want to jump into our survey in a second so we understand who we're speaking with this evening. But ladies, would you agree with the statement of I've heard more reversal cases of PCOS per se than endometriosis, insofar as if you understand what can be driving your PCOS and you're not kind of one of those more severe, significant cases, oftentimes I see a lot of women being able, like Dr. Varden, to reverse it to a certain extent where it's something in the back of the mind. We're like, okay, cool. I need to keep my lifestyle in check so this doesn't come back. But it's something that can be reversed and then very well managed insofar as it's not part of day-to-day living. I'm seeing some nodding heads, so I'm seeing agreement there. I haven't seen that as often with endo because I think there's a lot more to that. But with PCOS, especially given it's that huge spectrum where so many people can be included, there's a lot more instances of reversal. And that's really where a good care practitioner. Any disagreement?
Yeah. I was thinking about the endometriosis. I think the
Yeah.
challenge is by the time the symptoms present, you have tissue in the wrong house, right? Like your tissue escaped your uterine house and is now hanging out in your neighbor bowel house.
Little row.
And that's the
Yeah.
challenge because really you can't get it to creep back into the right house anymore. Right.
Mhm.
And so it almost always has to be surgical intervention to, at least if the goal is to get it off the tissues. And so to some degree, there becomes a management, and we definitely do this. We look at it as, okay, let's do everything we can to support those hormone pathways to reduce all of the risk factors that are modifiable, so we don't get it, because it can grow back just like vines that you cut off the side of your house, and the next summer they climb all over it again. You're like, okay. So I think part of it is almost, there's a part that we don't have visibility to until it's already present at a way that's so symptomatic.
Yeah. Very good qualifier there. Thank you. Okay. I'm going to jump into our survey to understand who our audience is with us this evening. So the first question is, what's your age bracket? And that really gets to, are you still actively managing the menstruating or the hormonal influence of this? So a majority of our audience this evening, 60%, is 50 and above. We have the next at 20%, you're our solid 40 to 49. And then the remaining 20 is below that, split evenly between their 20s and their 30s. So welcome to the multitude of people who are here with us this evening, be it a female who's concerned for their health, or separate to that, a male who cares to learn about this and support those who are in their life. Yeah. All right, our next question is, what are you looking for? And I think this will really guide how deeply we dig into the treatment side of things. What's your primary concern? We have a lot of people, 20% seeking to manage PCOS, 5% seeking to manage endometriosis. And interestingly, that captures the population spread. Approximately 10 to 20% of females will be diagnosed with PCOS, and approximately 5% of females will be diagnosed with endo. So it's interesting that mirrors so well there. 45% trying to understand the genetics of these conditions. And then I love this 30% looking to understand how lifestyle, exercise, etc. Might come in to support these conditions. So I think we'll really dive into that next. There's a solid, interesting, curious 6% who said other. Please add that to the chat. Love to know. And our last question this evening, have you been diagnosed with any of the conditions? So 30% of our audience is speaking to PCOS, 10% to endometriosis, and 6% saying both. Okay. Love to, we were discussing that co-presentation earlier at the top of the hour. So welcome to the both, and we'd love to be of support here because that's quite an incredible thing to navigate. 55-ish% of our audience have neither. So thank you for coming as advocates and allies to understanding women's health. All right. So why don't we get a little bit more specific? Why don't we get more specific as to, and maybe Dr. Steady, you kick us off a little bit insofar as how do we start approaching these cases? What considerations can we have? Because I think we've tossed out herbs, we've tossed out lifestyle, we've tossed out medication and surgery. So let's park surgery for a little while, and why don't we dwell a little bit more on kind of the non-surgical, more accessible to a certain extent options. So when someone presents with you, they're diagnosed or they're on that course 2B of either endo or PCOS, with appreciation, they're very diametrically opposed. What are the first things that you're thinking through, Dr. Steady?
That is tricky because I'd be thinking through different things for each of the conditions. So the most important thing to me is always what's bothering them the most. So I would be asking what their biggest symptom is. And for endometriosis, a lot of times it's pain or it's infertility. Those are the two main things that people would be, those would be their chief complaints, for lack of a better term. And I would actually go about things differently depending on whether it was for fertility or whether it's for pain. Because if it's for pain, you can use herbs that you can't use if someone's trying to get pregnant. So that's why always make sure you know the goal of the patient before trying to figure anything else out. But one thing that I will say that has been shown to help with pain is regular movement. Even though, from a Chinese perspective, stagnation creates pain. Where there's blockage, there's pain. Where there's pain, there's blockage. So that's just sort of one of those Chinese medicine sayings. And exercise in studies has been shown to help people with their pain management in endometriosis, even though the last thing that someone probably wants to do. I'm not saying that someone would have to do that on the worst day of their cycle or anything, but all of the other days, that is something that will help. And then now I would definitely be looking at their genetics, and also trying to keep their inflammation down, being careful about what they're eating for inflammation, stress, going over some meditation, breathing techniques, things like that. For PCOS, it would depend what their symptoms were once again, but, really trying to manage the blood sugar piece, and once again, looking at their genetics and trying to figure out, what their hormone picture is. What is there too much of? What is there too little of? Those are the kind of the two baskets that Chinese medicine puts things into. And it's really not that dissimilar. Are you estrogen dominant and you don't have enough progesterone? It's sort of the same thing. So just trying to balance all of that out with supplements and herbs. And once again, stress management. And there can be a lot of, depending on the presentation of someone's PCOS, there can also be this sort of body, I don't want to say shame, but people are self-conscious sometimes about their symptoms that they don't feel like they can control. And so really also keeping an eye out for the emotional impact that all of this has on them. Infertility is really hard. Not wanting, being worried that a whisker is going to show can be really hard. And depending on the age that's happening, it can be, for someone who's in high school or something like that, that can be a really, really big deal. And I'm not saying it's not a big deal if you're in your 20s or 30s, but I think the teenage years are very tender, and I feel very protective of that age group. So that's all that I can say for right now.
Oh, I love that. And thank you for raising that, because I think within conventional medicine in particular, that consideration of what is your experience in the world with this condition isn't always there. And it is usually the biggest driver to getting someone into clinic.
And I gotta say that hair on the chin, even when you're 50, really sucks.
Yes, it does. Because the rule is, if you can see it from the sunlight in the rearview mirror, you better tell me. It's a real thing. And I never had hair. I was not hairy before, but dang if I'm not now. It's interesting. I want to say a couple of things on that. I want to say too that I think we have a very cursory understanding of polycystic ovarian syndrome and the complexity of it, because there are a lot of women out there who exhibit a whole lot of the symptoms, but the one thing they are not having is they are not having complete lack of periods, or very, very distant periods. Because the reality is you could be having a period and be anovulatory, right? So you could be having a period and not actually shoot an egg out of your egg carton, for everybody, which is what anovulatory means. And it happens when we're in perimenopause, into menopause. But I think a lot of women and girls are getting overlooked or being told it's something else that really are having that, but they're not ovulating, right?
Yeah.
But they're having the joy of the period, just because we want to always have that. But I think there's that. And then there's also women that when you get to your 40s and, you know, and progesterone levels are on their natural decline, right? You end up in an estrogen dominant state anyway. You can get polycystic ovaries at that time because the other hormones are out of balance. And then you go, have I had this all this time? And I don't know, potentially.
I love that very beautiful, graceful admission that the course and the nature of this changes with time. It's not something, if you had it in your 20s, you can't get it when you're in your 40s. Yeah. Yeah, I love that. Thank you. And I'm curious again, I want to shift to Dr. Varden in just a second to kind of understand maybe genes that she's considering when she sees someone with either condition and is trying to form up a clinical plan there. But for those in the audience, if you have, and again, you can make this anonymous if you want, but if you are someone who identified as having one of these conditions and there's a specific symptom that you want us to be addressing or focusing on, please do toss it in the chat so that we can start to kind of ensure that this part of the conversation before we jump into the Q&A captures what you were hoping to better understand. Yeah. So Dr. Varden, someone presents, Dr. Steady offered endo first and then PCOS, but for those conditions when someone comes in, what genes are you considering? So obviously their hormone profile.
Oh, absolutely. And again, to reiterate what Dr. Tracy was saying, you got to know what their complaints are, what are going on, what's going on with them, and then looking at their genes. So let me start with PCOS and like some of the symptomology and things that I would look at. So I would look at their androgen conversion. So genes related to testosterone and androgen conversion, these are your CYP17A1. So I'd be looking to see if there's a G allele, a faster conversion to testosterone. Another one, the SRD5A2. If there's a G allele, it's a faster conversion to DHT, dihydrotestosterone, which is 3 to 5 times more potent than testosterone itself. I mean, we as women don't really want that to be very fast, but there are some benefits of it, but when it comes to PCOS, that faster conversion can lead to that type of presentation, because again, these all are linked to higher androgen levels, as well as their clearance, the glucuronidation pathway. So these are the UGT genes and the CYP3A4. How fast are they clearing testosterone? Because if they're not clearing it very fast, then there is this reservoir of testosterone concentration that just kind of keeps building. I mean, really, it's looking at all of the pathways. Also, how well are they binding to the androgen receptor? That can play a bit of a factor in there. But those definitely, the main ones, they contribute to those PCOS symptoms like acne, hair growth, hair loss. Also, I would look at their estrogen conversions, the CYP19A1 gene, the aromatase gene, because if they're a carrier of a slower allele, the C allele, that can lead to less estrogen conversion. Again, also, higher androgen amounts. This can exacerbate the hormonal imbalance, potentially influencing that ovarian cyst formation and the menstrual irregularities. Then, because we don't want to forget about this, as this really is super important that Dr. Steady had mentioned, the insulin aspect. So looking at any insulin resistance, obesity risk, and I had mentioned this earlier. So the FTO gene, fat mass and obesity gene, okay? The TCF7L2 linked to your insulin response, that can contribute to that insulin resistance, weight gain, and PCOS. And I also mentioned about AMY1. Okay, involved in starch metabolism that can affect weight gain if there's any decreased metabolic response to starches. Also looking at the ApoA2. I mean, there's just this plethora of things that really make a difference. I know it's kind of like, oh, let's go through the whole thing, but they do impact in certain ways.
Yeah. No, I love this. So I wonder if there's anything else to add, Dr. Murray. I'm looking at you in particular because I value the number of women that your clinic supports here in this space and the clinical pearls that I know you just kind of have oozing out of all the goodness of you.
You could feel it. I had something to say, right? So particularly endometriosis, I would say we know a little bit more about this. So your estrogen clearance pathways, so your CYP1A1 and 1B1, if I have a slow slow A1 and the 1B1 is mutated, right, where I'm making more hydroxyestrone, particularly the 4-hydroxyestrone, those are associated, higher amount of 4-hydroxyestrone, lower amount of 2-hydroxy with endometriosis. Right? Because you think about it, and it makes complete sense. The estrogen burden is going to be higher. And then if we add toxicities and things like that, we just have a higher likelihood for that. The other thing that I think is really also undervalued is the COMT Val-Met 158. That one also bit of an indication because, again, you're sort of marching estrogen to the exit door, but along the way it's getting slowed down and impaired. And then downstream from that, how they actually get out of the body. So, those are things. And I think when you can marry those kinds of results with hormone metabolism, urinary testing, like the Dutch test or the HUMAP, and even things like organic acids, where you actually see these genes in action, that starts to help you marry the genes with what's really occurring at that time. So you get a really clear picture of what's really happening now.
I love that. So part of your intake, part of your ethos very much is appreciate the patient and do a lot of testing, especially to monitor as treatment is coming along.
Yeah, because I think it's really important too to understand, to Dr. Tracy's comment, is it's the epigenetics that really drive what's happening. The genes inform where you're probably going to go, right? But you got to turn that, you can turn it up and you can turn it down. And when you add those tests, whether it's urinary hormones, OAT tests, or even blood, some blood tests, that starts to give you an understanding of what's getting turned up. And so, there might be cases, let's say, of an MTHFR SNP, but you're eating in such a way and getting the nutrients in such a way that it's not really being expressed. So you don't need to do some high dose methylated folate, right? And I think that's where a lot of things get lost in the translation. Is I think it's always valuable to sort of pair those pieces together, because then you're really getting into the nitty-gritty of fixing your biochemistry.
Yeah. I like the idea too, especially of those like treating and then seeing the person through lab values as well as in like through visit. I think that's very important too, because I interestingly, I think I love that you mentioned COMT, right? So COMT really looks at methylation, how we go about clearing our estrogens. And so I think a lot of people will hear, hey, if I modify COMT, it's going to help with my estrogen. And they'll do that almost to excess, right? To the extent of it will help with their estrogen clearance, but then they come up more depressed may not be the word, but almost just struggling with emotions, because that shifts how the brain processes things, right? And so really being emphatic here around the consistency of care and access to care and working with someone like any one of these beautiful women on our panel today who's very passionate around not only understanding exactly what it is, but separate to that, being consistent and present in that follow-up, because we don't want you veering off one way or the other.
Yeah, because more isn't always necessarily better. It's not how the body was designed. I love TCM for that reason, and Ayurvedic medicine both. It's like there's seasons and there's times and there's things, and there's always like homeostasis and balance, and that's what we're going for. We're not going for the extreme.
Yeah.
Yeah.
Well, and I love living in a day where we have access to testing. so that we can see how things bear out. And so when I
Yeah.
see someone and I have their genetics and I have their Dutch test, sometimes it's like, okay, this Dutch test makes total sense based on their genetics. And then sometimes I'm like, huh, that I would not have I would not have thought this was the same person. This is fascinating. What's
Yeah.
happening here? And
Yeah.
that's also a fun puzzle. But
Yeah.
but that speaks to very much what they're doing is altering, what how the blueprint plays out in real life, right?
Yeah.
Yeah, or what they're being exposed to that they may not even know they are exposed to, like all of the endocrine disruptors, the estrogen mimetics, BPA, register receipts, all of these chemicals that are in our food, soil, water, air. I mean, it's just, we are inundated. And that's why detoxification and supporting your detox pathways are so important.
Yeah. Yeah. I'm always shocked every time a new headline comes out that says like, hey, here's a way that you're poisoning yourself. Like the receipts, I've heard that. And it just, oh, mon Dieu. D'accord. We're going to shift into Q&A before I go down a rabbit hole I don't want to go down. All the women on this panel, I'm sure, could go down this rabbit hole for hours. It's important. Environmental medicine is important because it is shifting the presentation of these concerns, right? Our first question speaks to infertility. And I think historically that was something, maybe we started addressing in the 30s and starting to see those concerns come as early as mid to late 20s now. Yeah, so let's shift into our Q&A. The first question we have here, and Dr. Varden, you can hold me honest to the pronunciation because I always forget this. Alyssa?
Yes.
Alyssa? Okay,
Yes.
there we go. So when we discuss infertility, just getting pregnant, but not being able to keep to full term, also, is that considered infertile, or is this due to some unseen thing? So I think this was birthed from both these conditions, endo and PCOS, will have significant or can have significant impact and consideration to any plans of fertility, as well as ability to maintain pregnancy. And so I think possibly this question is better addressed by itself. That said, I think specific to these two conditions and to fertility, do we kind of want to start a conversation there around how these two conditions will impact fertility, and should you be of an age and a desire to be fertile, what you need to be thinking through and how you can support yourself?
Yeah, I mean, I can say a little bit to the, so if we look at endometriosis, depending on what's happening in the uterine lining and of course the hormonal sort of combination, there can be fertility issues with implantation. You might be able to get an egg and sperm together, they just don't implant and maintain. And then there's also complications from if there's endometrial tissue that might be on fallopian tubes or other things, they can actually affect the ability of the egg to get where it's going. I think that's from a just sort of systemic physiology, what may really happen. And then PCOS, because progesterone often is relatively low to estrogen, you may not ovulate. And progesterone's other major role is just like what it sounds like, progest, is to really prepare and keep a egg to become a fetus, to become a human. And, if it's not really well managed, or you don't know this is happening, you can have pregnancy loss and or just a lack of ability to get pregnant in the first place because progesterone levels are relatively low. I think that's like a very basic sort of discussion to that, right?
Do you think that those types of situations would still be relevant for someone in their early 30s, good health, getting pregnant, the embryo does go into and on the uterine lining, or the endometrial lining, but can't carry to term past that first month? It's just that first trimester we know is so tenuous, but not being able to carry it past that week 10, 12.
Yeah, I think there's a couple things that come to mind when I think of that. And as a disclaimer, I'm a PhD on the nerdy side of medicine. I'm not a gynecologist. I don't deliver babies. However, the other thing I always think about too is you're going through fetal development. So you got to remember, inside the cells, we have cells rapidly, changing and mutating and making different cells from germ cells. There are gene combinations coming from the mother and the father that, MTHFR is associated with early loss of fetus, right, within the relatively short period of time. So there can also be things that your body's actually saying, hey, this is not the right combination of genetics at this moment. Doesn't mean that the next combo won't work, right? Because depending on what SNP you have, like let's say you have 677, you've got, one mutated gene, one non-mutated gene, whatever 1298 is doing, you could have a situation where the father and the mother had the combination that came together that made it contrary to life. You will never see two mutations on MTHFR at 677 and 1298 on both sides and have any fetal developments. It cannot happen in science. There's other things like antiphospholipid syndrome and some other autoimmune conditions that can often get overlooked that people don't know, but those are often the pregnancy losses that may happen in that latter part of that trimester, and especially after that first trimester. That's where we start to dig in and look if that's possibly what's going on, because you can have microclots that are occurring and other things from that. And so I think, we tend to be really proactive, and we sort of check all those things in advance if we are getting in advance of a pregnancy, just because conventional medicine says, oh, miscarry once or twice, and then we'll start maybe looking, because it just happens. But it's brutal and emotionally just horrifying to go through.
Yeah.
Well,
Yeah.
and the statistics around fertility with these two conditions is worse than the general population. And so that just needs to be kind of kept in mind. It doesn't mean that it's impossible. Certainly, it's just that it's probably more complicated, and probably people need more than one person on their team helping them to navigate it.
Yeah. I love that. I think that's very succinct and well put, and further evidence of the personalization needed for medicine here. Yeah. The next question we have here is from Elizabeth. And this goes specific to endometriosis. So she's asking, what is the mechanism that leads to spreading outside of the uterus? So the endometrial cells, that endometrial tissue, what's the mechanism? Do we know that specifically? I know that. I know it usually goes back to to infancy, I think, to a certain extent, and to teenage years. I don't know if we know the exact pathology, though. Is that an honest statement? Can anyone challenge me on that?
I would say it's if you look at the behavior of the tissue, right? It's a rapid turnover tissue. It's a highly vascularized tissue. There's also things that disrupt that tissue. You have your cervix, basically, and then you have your endometrial lining. A lot of women end up with endometriosis even post-pregnancy. And so you can imagine you're, getting rid of a baby, pushing it out, and you have a lot of change to that. You have the dilation of the cervix and other things where tissue is getting exposure. How it really works, I would say we know that it does it. Why it does it, I don't think I can answer that question. I don't know about anybody else.
I think science is still let's be honest about this. Science has not investigated this very well for strong political reasons of women's health being just male health. So I think we're in the efforts now of investigating the exact root cause. But I think that's by and large the theory, right? A little bit of gestational, and then coupled with through adolescence, that development there. Yeah. Okay. Nicole is asking a question. Okay. So she's saying that she has 1 or 2 cysts on her right ovary and have had them shrink and grow over the years, which is very common, Nicole, based on hormones, based on when you're getting imaging, et cetera, et cetera. Does this presence of ovarian cysts mean that you have PCOS? I love this question in light of increased imaging, because the answer is maybe, but also no. I saw Dr. Steady nodding vigorously. Maybe do you want to start in on this one?
So first, you don't actually have to have that many cysts in order to have PCOS, but on imaging, if that is a symptom that you have, a lot of times they say it looks like a necklace. Like there are many of them. Like I've seen ultrasounds that show it, and that's what it looks like. If you think ovaries are sort of like the eggs are sort of almost like cysts themselves. You know, they grow and then they rupture and they do this whole thing, right? So I think of them as sort of a cystic kind of organ, you know, more than another organ like the liver or something, you know. So I wouldn't necessarily say that if you've had two that kind of come and go, that's a definition of you having it. If you have, in the absence of other symptoms, I would say no. If you have other symptoms, it's something to consider and rule out or not rule out.
Yeah.
That's my answer. Maybe others have different answers.
Yeah. Oh, please. I think we're on the same wavelength. We're going to say the same thing. Go ahead.
Yeah, and I think we have to understand that the natural action of the ovaries is to get the egg out. It creates a cyst that's fluid filled, and the hormones do that. And then it pops open, and then the egg flies out like a jet wing fighter, you know, and goes into the fallopian tube. So every time we ovulate, we develop a cyst, right? And what makes it polycystic is it's like a piece of popcorn that never made it out. So when you look at it, it looks like popcorn all over it, right? So we make them and they go down. And so when you're often a little bit older, sometimes we do that and it doesn't pop out. And so you can have some located, just one or two that are just happen to be there.
Yeah. I think, Nicole, one of my first questions as well would be really like what instigated this scan? Was it specific to your investigating PCOS? Or was it more incidental? Incidental meaning you went in to do an ultrasound of something else and then you found this. And so as we get more and more imaging, access to imaging, the interesting question within medicine is, you know, have people always had this and maybe not everyone's symptomatic, right? Having a cyst based on this, I love this popcorn versus not string of pearls, right? This does not mean necessarily that you have these conditions, but if you're investigating those conditions and then you find this, you know, it's pointing you in the direction of possibly yes. So be mindful of why you went in for that imaging and things like that, right? Imaging is not necessarily diagnostic all the time. Depends on what it is. All right, next question here. I'm not sure how to pronounce your first name because I think it's just an abbreviation, but we have a question here that says, is there a supplement that can assist in balancing out high testosterone levels? Also, can blood pressure be high from PCOS? So I guess two separate questions. Is there an herbal family or a supplement family that can speak to higher testosterone levels, which is often associated with PCOS? And then separate to that, do we know if PCOS can influence blood pressure? Yeah. Anyone want to?
Tracy, do you want to talk herbs or, or general?
Well,
what do you
yeah,
think?
I mean, I think that the issue, I can name some, but you wouldn't want to just Google them and find them on your own because and I'm not saying that to be withholding in any way. It's just that it's part, you would want someone who knows about them to help you, because certain ones are better for other people. Things need to be ruled out in terms of contraindications and interactions with other things that you might be taking. And also, even two herbs that both do that, one of them is going to be better for you than the other one. And so, and you don't want to, so a lot of people just will then take all of them, you know, and that's not like Dr. Murray was saying, more is not always better. And also they're difficult to pronounce. And if I said them, good luck Googling them anyway.
She knows the Chinese names. I love this so much.
Yeah, we learned them in Latin and Pinyin. I don't even know them in English unless I really try really, really hard. There are some other things that are widely known about on the internet, like inositol. Once again, I'm not recommending this for anyone in particular on this webinar. I'm just saying that that's something that is frequently used in PCOS for both for blood sugar and for managing the hormonal aspect of it. Yeah, I guess I'm complete.
Yeah, I
Yeah.
like that. And Dr. Murray, I'm gonna let you go in a second, but I think Dr. Steady's being very humble in her herbal knowledge, but I think it's really important to appreciate while a few herbs might be popularized, just like a few genes might be popularized, that doesn't mean you know everything about it. And often, especially in Chinese medicine, it's the combination of, it's rarely one herb by itself. And I think especially in Western medicine, we have this idea of, oh, I'm just going to give you white peony. I'm just going to give you this other herb. And that's not necessarily what you want to be doing, because they're better in concert than they are solo artists. Yeah, not everyone gets to be a Beyonce. It's usually Destiny's Child. All right. Does anyone want to speak to blood pressure?
Yeah, so blood pressure can be part of the constellation of things, particularly if there's inherited insulin resistance. So for that phenotype of PCOS, because we have those things, and androgens, we have the H gene and other ones that can contribute to increased levels of angiotensin, and sometimes that will appear as well. One of the things that I think pretty much universally, I would agree, like Dr. Steady, like we don't, you want to be really careful about, hey, I just read about this one herb, I'm going to go take it, and then I'm going to stack a bunch of herbs, not really knowing what your chemistry is really doing, because there's a lot of different ways to fix that. But the universality of need for magnesium is always a good place to start, right? When a woman is pregnant with preeclampsia with really high blood pressure, we give magnesium, right? So having a little bit of extra magnesium often can help. And that's something that's kind of not going to interfere with other pathways in any major way. And chances are it's going to help with other things like sleep. So checking your magnesium level and maybe even increasing magnesium, I would say almost everybody universally when we test them needs magnesium.
Yeah.
Like we joke, it's like, while you're waiting for your appointment, start some magnesium and then we'll just, keep going, because it's almost always needed.
Yeah. 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 It's one of the few almost default prescriptions that you could say, almost like vitamin D. Go ahead. Almost. Consult with your clinician. All right. Next question that we have. And Dr. Murray, this speaks so beautifully to kind of what you alluded to, that these conditions will change based on where you sit in your menstruating life. So Claudia's, it's a little bit of a statement and a question. She's saying that after menopause, endometriosis changes. There's still issues with scar tissue, though many earlier symptoms and problems are reversed or altered. So I guess, do you want to elaborate a little bit on what Claudia is saying there?
Yeah, so because endometrial tissue is stimulated by the variation in the hormones, particularly estrogens, as your estrogen levels decline in menopause and then go basically to nothing, now you don't have a hormone stimulating that tissue to do its job, which is bring a lot of blood supply to the uterine lining. So often, if we had very painful endometriosis, one of the few benefits of menopause is actually seeing a reduction in those symptoms. Yeah. The scar tissue still exists because it often creates scarring and those kind of things, but the stimulation is now gone. And so that may be why you're not feeling those same symptoms anymore.
Yeah, I love that. But yeah. And I think, oh, please.
I just wanted to make a plug for pelvic floor physical therapy, because one of the things that it works on is the structure, which can be altered from endometriosis kind of collecting in places and things like that, and making sure that when you're using your body, because we all want to be moving, that you're not reinforcing a pattern. They can help you balance things out, strengthen things, loosen things up in there. And I know that it might sound strange, and some people have never heard of pelvic floor physical therapy, but it might even be covered by your insurance. So check it out.
And to that note, the other thing that happens with menopause is urinary incontinence and if uterine prolapse, there's all kinds of things that aren't working down there in the same way because of loss of hormones. Pelvic floor therapy absolutely can help a lot before you ever look at hormone replacement or not.
Yeah. I thank you both for bringing this up. I think, interestingly, it was something, at least in my mind, I had chunked away as, post-pregnancy or, preparation thereof, or maybe if you've had complications. I've always associated it with pregnancy. And yet recently, again, I roll within a very crunchy granola crowd, but some of the females within my life, independent of these sort of things, they're like, oh, I've started doing this for my own health, be it just to the better my body, to better my experience of the world. And they've had marked improvement simply from learning these sorts of exercises, getting assessment, and understanding even just how they carry their body in the day-to-day will influence pelvic floor and associated, the organs that it supports. So for the women on this call, right, if you're struggling with one of these conditions or separate to that, just for your own wellness, because this is not advocated enough, for your own wellness independent of fertility or medical concern, go get yourself checked out. Yeah, especially if it's part of insurance. Yeah.
Yeah.
We always joke. Oh, I'm sorry. Go ahead.
I was going to say it also helps with sneezy pee.
That's what I was just going to say. You never trust a cough or a sneeze. Never. You got to cross your legs. You just never know what might happen.
Those Kegel exercises.
Yeah.
It's real, but pelvic floor exercises will absolutely improve that.
Yeah. Also supports good sex life, which is very important and we don't talk about enough. All right. Yeah. Now to cut myself off, I'm going to move on to Jill's question. All right. So Jill's asking a question here. She is moderately androgenized, meaning I don't know if she's referring to her hormone profile or just a higher presence of testosterone. She is 52 in menopause on BHRT, a combination of estriol and estradiol. It has helped her manage her menopause symptoms. She feels very balanced with the exception of unwanted chin hair. Look in that mirror. She's tried fenugreek, black seed oil, saw palmetto, and they haven't really helped. Any further suggestions for specifically the unwanted hair? Yeah. So before I take any input from the doctors, Jill, really we'll dwell in a little bit. There's an element of you do need to see a clinician because kind of stating age and a little bit of history isn't going to get you the exacting answer, but we can definitely, toss a few thoughts out. So ladies, outside of tweezers, any thoughts around unwanted hair?
I think about having your labs done. This would be where a Dutch test or something like that to look at your, particularly like dihydrotestosterone and androstenedione pathways. Are they amplified? There is a little bit of a reality to this that as we go through menopause, our androgens relative to our estrogens are going to be the teeter-totter has done this a little bit, right? Not testosterone usually, it's the other ones. Right. And so we get fuzzy, we get the peach fuzz, we get the chin hairs. And the other thing is you may also look at your estrogen levels and make sure that the bias that you're on is adequate as well. Right. Those are things that you can work with your clinician and sort of check on it because those other things that you took naturally will often affect DHT slightly, but it may not be enough.
Yeah. Yeah, I like that. And then I think also to the queer, I think understanding what's important to you and then chasing down the right things too, right? Yeah. I think
and I'll just be honest, I have chin hair and I don't have high DHT. None of that stuff is high, but I have chin hair anyway. I just have to carry tweezers.
And one of those magnifying mirrors.
It's just
yeah. And then holding space for it's just going to be there. And so learning to an extent to comfort with self, right? There's something that's inevitable. And just because you're told it's not supposed to be there doesn't mean maybe it can be for you. It's up to you. I think that's where choice comes in. Yeah. All right. Deborah has a question here. And so this kind of gets to the idea of PCOS as a syndrome. So is there a distinction between having continuous cysts on your ovaries and a hormone imbalance, and then having PCOS? Like, are there degrees of it? And so I imagine this question kind of was birthed out of our syndrome talk. Would anyone like to just, again, offer a quick summary, maybe Dr. Varden?
Well, I mean, Dr. Murray actually said and explained this so beautifully, when she was saying about, every time we ovulate, it creates that cyst. But, when we're talking about distinction between having a single or continuous cyst on the ovary. There are distinctions. And while all of these can be related to ovarian health and hormone regulation, PCOS is a specific syndrome diagnosed by meeting certain criteria. Okay. And obviously by your doctor. So this would be, for example, ovarian cysts versus PCOS. Ovarian cysts, the fluid-filled sacs that can develop on the ovaries, like Dr. Murray was explaining, relatively common. They can occur due to various factors, hormonal fluctuations, the endometriosis, or even normal ovulation, okay? And many women experience this. But with the PCOS, that is more of a hormonal disorder that includes the presence of multiple cyst-like follicles on the ovaries. And, obviously, like Dr. Steady has been explaining, that it also comes along with many other symptoms that have specific criteria, not solely on the presence of cysts. There is a PCOS diagnostic criteria called the Rotterdam criteria. So if PCOS is diagnosed, if a woman meets at least two of the following three criteria, this is often done. But again, this is just informational. You still have to go to your doctor, have them do the diagnoses, but generally it's irregular absent ovulation, hyperandrogenism, where higher levels of androgens, okay, and polycystic ovaries, those appearance of the multiple small follicles, and really try to, as far as like degrees and variability, I mean, there are certain things like complete PCOS. This is meeting like all three of those criteria. Okay. There's ovulatory PCOS. That's like having polycystic ovaries and high androgens, but regular cycles. Or there's like non-androgenic PCOS. This is irregular cycles, polycystic ovaries, but normal androgen levels. I mean, there's these different combinations. So
alphabet soup there.
Yeah. It really needs to be assessed, by your doctor, because there's so many nuances there.
Yeah. And I want to
have a rogue cyst. You can have just a rogue cyst that stays, stays little piece of popcorn that doesn't really do much, but it happens to be present, right? And it may not ever do anything.
Yeah. I think I like your point, Dr. Murray, in the sense of not over pathologizing everything, right? Sometimes it is just a piece of popcorn that's just going to hang out for the rest of your time with you. Yeah, popcorn's yummy. All right. So I'm going to dovetail this a little bit. And as I do, Clara, you asked a question, but I think it was in the moment, so I don't really have context for it. It was about menstrual phases. So if you want to offer a little bit of context as I offer this next question. So Erica has offered us a question via one of our live stream feeds, and she's asking, and I think this goes to Dr. Murray because you first brought this up. Can you talk more about lean PCOS? Is it possible to regularly ovulate and to have normal testosterone and still have PCOS? So kind of the picture that isn't entirely clear, and yet there still is suspicion thereof.
Yeah, definitely you can. So you can have, Dr. Laura was even talking about that, normal androgens, but visible polycystic ovaries and excess estrogen relative to all the others. And again, and I think here's where the nuance I think is. I think the lean PCOS may not have as impactful genetic profile and also insulin control profile as a more classic presentation. So the interventions with, metformin and those kind of things do not seem to help because it is not a metabolic impact situation. Sometimes you can look at things like luteinizing hormone because it's often elevated. It stays elevated in general, right? Which is kind of what helps the ovary pop the cyst open. So that presentation can look like it, and you could still have cycles again, because you could cycle and still not pop that egg out.
Yeah. All right.
Yeah, that's the fourth phenotype D. I wanted to just quickly say there's an app called Ask PCOS, and it's a pretty good resource. It has like questions you can ask your doctor. It has, other resources in there. It's pretty good. You wouldn't want to use it to diagnose yourself, but you could use it to help with language and to keep track of your symptoms so that when you go to the doctor, you can give them a really succinct, this is what's happening to me at this time of the month. These are my symptoms. You know, this is a problem for me type of thing.
Yeah.
I love that advice so much because I find sometimes, especially to the end of it, takes a while to get diagnosed, and the emotional kind of toll. Sometimes you get lost in that and you almost walk in expecting I'm not going to be heard. And so I love that idea of collecting data, collecting words, and being ready for some of the questions so that either you can answer them or direct the doctor towards those questions. That's not a fair burden to put on people with any of these conditions, but I think it's an advocacy thing as a patient. If you don't have one of the wonderful practitioners here who's literate in these spaces and wants to hear and will ask these questions, how do you prompt them? Dr. Steady, I love that. Can you maybe toss that app into the chat so our audience has it?
Yes, and I'm also going to toss in an Instagram handle, Endo Girls, who are just two women with endometriosis. But I have heard from other professionals that there's a lot of information on there. And one of the things that they do recommend, once again, is writing up a timeline. This is when this started. These are the main points, because sometimes if you go to the OBGYN, they don't have a lot of time. You know what I mean? And so really having it clear in your mind so that you don't get nervous and forget half the things that you wanted to say that felt really important to you on the drive over. And then you got flustered when they took your blood pressure. Like, don't let that happen to you. Write it down so that you can make sure that you say everything that you need to say. And I'll toss both of those in the chat.
I love that.
I want to throw out one more tool that I think is really, really great. It's a device called Mira, M-I-R-A. So it is essentially, so imagine it's like a glucose meter, but it's for your hormones. And basically you have this little meter. I can't tell you exactly how much it is. It's not horrifyingly expensive. And in the morning you pee and then you dip this little dipstick in it and you let it sit there for a few moments, and then you put it in the Mira device, and about 20 minutes later, it's going to give you your progesterone and your estrogen. It was designed originally as a fertility device. We started using it because I work not just with, we do have fertility, but I work a lot with perimenopause, and my team works a lot with perimenopause and menopause. And what it does is you can do it over the course of the month, and you can kind of see, and you can see where they're varying. So, you know, you can tell maybe my progesterone is always low. That would arm you with data that you could use, but also data you could share with your doctor. And once you have the device, you just buy the little pee strips, you know, so you can also use it to track how you're doing, you know, very cool. I was super excited, of course, because I'm a nerd and I'm like, I love tech.
I know. And data, tech and data. All right.
I'll put it in the chat too.
Thank you. I think Eska, as part of our audience, did as well, so someone else is familiar with this, but thank you. All right, so Patricia has a question, and it's the beautiful of her tending her niece. So, and I love, actually, I'm very happy about this question because I think it ushers in conversations that a byproduct of a very popular drug. So her niece has PCOS, and she has a hallmark symptom of it, of very thin hair. Okay. In the past couple years, she's lost over 80 pounds. She exercises daily and has moderated her diet. She is also taking a GLP-1 agonist. So this is, you know, very much popularized as Ozempic, or, you know, facsimile thereof. And she's saying, but this has not resolved the hair growth issue. So do we have any thoughts around that? And kind of one of the byproducts, right, that these drugs have ushered in fertility in people who didn't necessarily have it before, but then separate, you know, it's kind of thrown on every condition to an extent right now, in the sense of, oh, if you have this, maybe we'll try this because I've heard it's worked. So you have someone with PCOS, you toss them on this. What are other considerations they should think about outside of the drug? And we'll kind of leave the controversy of the drug aside, but someone with PCOS on this, what are other considerations they should be thinking through?
I mean, I think of it as a nutrition professional is, are we getting enough protein? Do we have iron, zinc, protein deficiency? Because hair is protein and iron and zinc are required. One of the challenges with these drugs is often you're just not hungry. You get, you know, it slows gastric emptying, which is, you know, it has all these great effects for weight loss. But one of the things even the studies showed was that protein intake was often difficult to get in. And if you don't get enough protein, the hair is the last place your body's going to expend any of that protein. So if the hair loss occurred with taking the medication over time, it could be medication induced. And the biggest thing I do is look at, can I increase my protein intake? Can I get my iron and zinc levels checked also? Because that can cause hair loss that's exclusive to the hormones, like not even part of the hormones.
And I want to actually mention about stress.
Yeah.
During all of this, you know, what I am seeing that she has gone through, I mean, obviously very beneficial, you know, losing, you know, such a tremendous amount of weight, exercising, you know, being on the medication, but her body is still under a certain amount of stress. And stress will actually cause shedding of the hair. I mean, I will say, I know for myself, as well as with several friends and family during the pandemic, certain stressful times, or, you know, when they got sick with COVID, they ended up losing a lot of hair, and it took several months and even up to a year to start getting that hair growth back. Because when you think about stress, initial hair recovery can take 1 to 3 months. It goes through a telogen phase, that resting phase following a stressful event, you know, like illness, you know, drastic weight loss in her case. And this is when hair sheds more than usual. So that's after the fact, that 1 to 3 months. Then you've got that early regrowth, which is like 3 to 6 months. So after that early telogen phase, new hair begins to come back, typically growing about, you know, 1/2 inch per month, as long as you have those basic nutrients that Dr. Betty was mentioning. We've got to give our body, you know, the tools in which to, you know, to keep growing. But it can take a while, and it can still look thinner than before, you know, and it really does take, like I had said, what I had noticed, like 6 to 12 months and beyond for, you know, more of that growth recovery to happen, and for you to actually start seeing, you know, a bit more fullness. So we have to be kind to ourselves and realize, you know, what our bodies are going through, and to realize, you know, although we wish our hair would grow overnight, you know, really long and lush, it doesn't, but it will grow.
This is not a miracle for hair growth, but while you're doing all of the other things, light therapy can be a nice addition to it. The red helps with circulation and stimulating that, and the blue actually helps stop the hair from going through the phase where it falls out. So if you use a combination of the red and the blue, why not? It's not going to hurt you. Might help.
I like it. And it would
I
also
think we have to acknowledge the androgen aspects of it too. If we have elevated, this is where a clinician comes in, right? So if all these things are the nutritional, the light and other things, but excess androgens causes hair loss. It causes male and female pattern baldness. And a good clinician can work with you and come up with topical and also medications that can help sort of block some of that activity to keep it from happening and help that hair grow back. You know, so that's kind of the way I would look at it too.
I love that. I was going to usher in the idea of, you do need to test, right? Because just because you've lost the weight and you kind of addressed to a degree the metabolic side of PCOS, metabolics is not the only thing at play here, and hormones are. Yeah. All right. Clara asked a question. And I'm going to ask hers, and then we have one other from Jody. Clara said, can Accutane help with PCOS symptoms? So to offer a little bit of context to the audience, Accutane is a very high dose of a retinol or a vitamin A, and it's to the end of addressing acne, cystic acne. And cystic acne is amongst many of the symptoms or presentations of hirsutism. So thinning hair can be part of that, and then cystic acne. So she's asking, can it be very specific to addressing that? And if not, can you help manage PCOS well? And then I guess she's also saying, like, if you're on Accutane, is that a detriment to PCOS? Can you still manage PCOS while on that? So I'll offer this before our ladies jump in. We can't suggest anything around your medication. We can't shift your medication. And given you're on a medication and kind of saying, I also still have struggles with this, it's probably better you be seen by a clinician, because everything that we've said so far is you have to test and you have to consider this and you need to know this. So we wouldn't be offering you a good answer if we were to say yes or no. But I would offer probably by and large, yes, you can still be addressed as while on Accutane for PCOS, probably in a better way I would offer, because I think Accutane is kind of going after a symptom as opposed to root cause. That would be my first thought. Ladies, anything else to add to that?
Yeah, I mean, Accutane's really working at the skin, whereas when you're talking about what caused possibly the increased acne is really the hormone balance, right? So if you work with a clinician that can test it and figure it out and see if we can bring those back into balance a little bit, the need for Accutane may go away or go down. The other thing is if you are a reproductive female and you are on Accutane, you must be on contraceptive, right? It will cause fetal development problems. You do not want to do that.
Mm-hmm. Yeah, no, definitely. So also for the women that try to create Accutane themselves and do high dose vitamin A, liver damage and baby damage. So be very, very mindful when you're playing with these things. Okay. All right. Jody is offering our last question for the evening. So she would love to hear the connection between endometriosis and cysts on the breast. She has high density breasts. Any recommendations to dissolve cysts and prevent breast cancer? So perhaps maybe she's speaking to any connection. Is there a connection? And I don't know, I actually don't know this. Is there a connection between breast cancer and endometriosis? If you have endo, does it increase risk for that sort of pathology within breast?
I would have to say that. So we have to remember fibrocystic breasts do not increase your risk of breast cancer. It does not. It makes it harder for our somewhat antiquated way of imaging to see it because they're dense and you got to kind of squash the crap out of them to get a good view, but it doesn't make you at any greater risk. They're just lumpy, right? And lumpy breasts, fibrocystic breasts do have some association with higher levels of estrogen, some of the CYP1B1 pathways, those kind of things. So indirectly could they be related, but not correlative, like they don't show up together, all the time, at least in my studies.
Yeah, I haven't seen any studies in research, which is why I was kind of offering, I don't know, because I haven't dug into it specifically, but I'm glad to hear there's no known correlation. All right. I think before I thank our hosts, I've seen a few comments within the chat really asking, how can I engage with care? And I would imagine that's a little bit specific to what we're talking about, but then also just a general atmosphere right now of female care, women's care, being a little bit more difficult right now to access. And so obviously you're encouraged and welcome to engage with any of our clinicians that you have present here. Please do reach out to us separately. The DNA company, we're very aware and sensitive to that. So we are very we've been working on this for a while, but we're expediting some of that work to really speak to women, their concerns through all stages of life and how we can go about supporting their concerns throughout life. So from that menstruating, possibly fertile period up until, through menopause and those beautiful golden years, however you choose to live them. So keep your eyes and ears open to that, because we are really going to be offering into that space to ensure that women, females have access to good care. That's something we collectively, the four of us, passionately believe in, but also we as a company do. So keep your eyes mindful to that, because we're going to ensure that we're going to be part of the solution for that accessibility and the very heart-forward, compassionate conversations where it's not someone telling you, come back later, that is not actually a problem. Yeah. So,
and just to piggyback to that, first of all, happy birthday, Dr. Varden.
Thank you.
And excellent conversation, ladies. Dr. Steady, welcome to the panel group and being a part of this conversation. You were amazing, so thank you for that. To speak to what you just said, we will continue to support women at all junctures of their life and find ways to continue to improve upon testing and access and education and information. And we have people like Dr. Murray here, who is an industry thought leader, 1,000%. And we definitely will continue to do all of these things. So my email just got dropped into the chat window. And if anyone has questions about service, about access to service, if anyone has challenges accessing service that they need, please email me directly, and some of the concierge team or I will directly find a way to get you some help and support. So I just wanted to say thank you to all of you. This is an important conversation, and we're going to continue to have it.
Yeah, I think if you've heard the variety of opinions just on this panel, but our goal is not to tell you what to do. Our goal is to tell you what options you have, and then supporting you in whatever choice it is to whatever option you want. You're in the driver's seat. Our job is to educate and then facilitate, nothing else. So on that end, so Dr. Varden can get to her birthday dinner. Ladies, thank you so very much. It's such a timely, well-nuanced conversation that we had. I learned stuff, and I love when I get to come into these webinars and say I learned something. So ladies, thank you so very much for offering your brains and your hearts to this. We really appreciate it. To our audience out there, thank you for coming. Thank you to all the advocates of your own health or of people that you care about health or just your general advocation. We love it. Thank you. Please stay tuned, and we will see you later on. We can all dance out so that we can be happy in spite of everything that's going on. Au revoir, mes amis.
Bye, everyone.
Thank you, everybody. Team on the back end, thank you. Great job. Good night, everyone.